I recently have rebranded myself now too. I was in for just over 30 years in a private practice group. We're also the Department of Urology for Eastern Virginia, but now with UVA Health and kind of switched that. It's a hospital-owned, but part of UVA and still doing lots of BPH things. I don't have a disclosure slide, but I think like most of us, I've done all of these in some form or fashion or been part of a clinical trial. My task is GreenLight laser, which I've been doing a number of years. And I think most of you have had experience with this since it's been around, but it's some of the advantages with it. It is basically an outpatient same-day procedure. I do all in a surgery center. You can sure treat sick patients with it, usually less than an hour to treat. I think quicker than TUR in most hands. Again, world experience with it. And you can treat a wide range of prostate sizes and shapes that we talked about before. And it is the most common laser used. If you look at this graph on your left, basically the y-axis laser absorption coefficient and then the laser wavelength. So not all lasers are the same. The blue curve is water absorption, and then the red is tissue. So ideally, we're working underwater. You want the laser to be transmitted through the water, not the energy not absorbed. So you want that to be low in the curve, and you want the effect on the tissue. So you see the biggest gap there is the ideal wavelength, and that's patented, so others can't make a laser similar. If you move on down, that curve flips, so take advantage of the thulium and the holmium that we use for stones. Here, the energy is not put into the tissue, but put into the water, so we make the explosion, we treat the stone, and I've really enjoyed using thulium recently for that. So again, not all lasers are the same. Just in the essence of time, I won't beat this up too much, just a big study. They looked at GreenLight versus TURP. This was in 9 European countries, and basically concluded that equivalent to TURP in outcomes, but fewer adverse events, shorter recovery, and shorter hospital stay. We recently looked at this paper published in Urology, a review, GreenLight versus TURP, and basically concluded similar that shorter catheterization times, hospital stays, and lower rates of sexual dysfunction and bleeding is related to TURP. I think Kevin mentioned the patient experience, quality of life. When we're amongst ourselves, we're talking to amongst us, hey, patient's going to have a catheter overnight. It's no big deal. It's not to us, but lots of times to a patient it is. And I think that's something you want to look at when you're talking about therapies with patients also. Again, kind of comparing to some of the other things you've seen, pretty good outcomes with symptom improvement, flow rate, durability is fairly strong if you pick the right patients. And again, very much an outpatient procedure. One thing I do that I think well, I'll talk about that in the tips, but this was interesting. Boston Scientific, who manufactures the GreenLight, and now the third company that has owned that, got together a bunch of urologists who had a lot of experience with GreenLight, got some European doctors and said, all right, we want to make sort of to Dr. Ween's point, to simplify this, how can we get some steps because it is very technique dependent, unlike some of the other BPH procedures. And so we got all these docs in a room. I somehow got assigned to be the MC of that. And you'd ask one doc, well, what are the tips? What are your secrets? Well, I like doing it standing on one leg with a hand behind my back. And, I start at 115 up top. And, no. What can we all, you do a great job with that, but what can we all agree on that to help somebody who's just starting with this? So we basically came up with these key vaporization principles. So this is to vaporize tissue or melt it away, not cutting. That's a little different game, but these were kind of what we came up with. And there's actually a brochure. That brochure is available. It'll be at the booth next door. So these are kind of some of the key points and standardized things that we all came up with. It's very important to be close to the tissue to deliver that energy to the tissue, to vaporize it or melt it away. Sweep speed, most of us tend to sweep too fast. You got to do slow to deliver that energy, not too long of a sweep arc. And again, another thing I see in teaching this is fear to turn up the power. And I think the key with this And as I tell residents, if you're stepping on the pedal, you're doing one of two things. You're coagulating or vaporizing. Your goal with the GreenLight is to vaporize tissue. So you've got to heat that tissue to 100 degrees centigrade to melt it. We're working underwater, so to vaporize, you're going to create bubbles. So if you're not seeing large, big bubbles, you're not vaporizing, you're inadvertently coagulating, even if you're not stepping on the coag pedal, and that's what leads to the irritative symptoms. And again, I think that's what's held this technology up from really replacing TURP much greater than it has. And again, how do you treat the irritative symptoms? You avoid getting them. So again, doing the fundamentals, distance to tissue, sweep speed, power settings, turn that power up, vaporizing the capsule just like you do with a TUR. And again, just some pearls, if you can get patients off an anticoagulant, I think that's helpful. Start with low wattage and build up. Most of your bleeding is going to be at the beginning, that mucosal layer. You go through that at lower wattage where it's going to have more of a coagulative effect, and then turn up to vaporize. I tell the residents it's a sign of weakness to step on the coag pedal. You learn to do it by vaporizing and powering through. You want to vaporize to capsule. Arterial bleeding, important to recognize that and stop it, but the venous bleeding will stop with a catheter. And one thing in lieu of using CBI or irrigation, I started using a number of years back Lasix. So I'll give the patient 10 of Lasix about 10 minutes before the end of the case, and that kind of creates CBI from within and really helps that process. Clinical evidence have been numerous studies. I won't beat that up. Some docs tend to use it for their sicker anticoagulated patients. That's great, but again, it's technique dependent, so be sure you've got the technique down before you depend on it and using it on rare occasions. And just some pro tips, I think best suited for prostates. It really is a pretty wide range of size you can do. You can treat middle lobe. I think it's important, though, to know a really large intravesical middle lobe, I think more challenging. And having done it over years, that tissue can try to grow back. They can bleed. 5-ARIs work well for that. But again, if you want to avoid that, there may be another therapy to think about. Catheter, generally just overnight, usually 20, 22 French, depending on the level of bleeding, to use a 30 cc balloon. Teach the patients how to remove that. You can do ejaculatory sparing, probably 75, 80% effective. You just can't guarantee that. I think that's important to counsel the patients. Do not use it in patients who've been radiated. That tissue is already devascularized. You're going to devascularize it more and can get some horrible complications from that. And it is truly, I think, the best and safest for anticoagulated patients. And with that, thank you.